In the current system, whether you do a good job or you do a bad job, if you still are a patient, you get paid the same. And actually, this new model actually will reward the better providers with gain sharing, which is kind of a nice, a new way of approaching payment for professionals. What Steve was just describing is really shown in this slide. At the end of the year, you have each one of these bars would represent the average cost for a specific provider per episode. So obviously, we're not expecting every case to be the same. There's going to be biologic variation. There's going to be just things happen. And so we will have, a lot of this will be risk adjusted. Major outliers will be removed from your pool. So if somebody had some sort of catastrophic event, for whatever reason, it would not be in your average cost. And as you can see, we then array each provider by their average cost. So at some threshold, which would be set by each payer, you would see that up here, you would have a few folks above that line. And those folks would be potentially liable as being high cost per episode provider, and again, with a certain minimum number of cases, to be at risk for 50% of their costs per case above this line. Now, we obviously don't want to put people out of business or give them a significant penalty, so it would be for Medicaid up to 10% of their total Medicaid reimbursement. Now, I will say that we have been giving everybody their report cards prior to being put on the clock, if you will. So July 1st, in the first episodes, people got report cards that gave them an analysis of where they were on this grid and if they were in this high-cost zone. And we have been actually talking to a couple of the providers that were in that zone, and they've learned interesting things about their practice because we've given them their costs for medications, their costs for outpatient surgery, ER use, what have you, and they've learned quite a bit and while making adjustments to their practice style. And again, it is for the total cost of care and not just their professional fees. But for the most part, the vast majority of physicians and providers, whether it's a hospital or a provider or a physician in the state, are in the zone below the acceptable. And if you're in the acceptable to the commendable, you're in this gray zone here. That meant that you are okay. You got your fee for service. You are in a zone of average cost that puts you in kind of a gray zone of it's okay, and nothing happens. You've got your fee for service, and that's it. You're done. Then you have folks here in the commendable area, which are folks who are more efficient or more effective. They actually are below this commendable line and above this gain sharing limit. And these folks actually will share 50%. They'll get a bonus payment of 50% of their savings per episode compared to the commendable line. So they actually are being rewarded for having an effective profile per episode. And at some point, you get to a point where we're not sure you can go below that limit. So if there are a few providers that go below what we call the gain sharing limit, we put a floor in, so we stop the gain sharing below that limit. Mainly because we're not sure it's necessarily appropriate to go below that limit. Maybe it is. You can show us why. But we're just being cautious that we don't want people cutting corners or doing things a little bit avoiding costs that maybe they should be incurring for good care. Next slide. These are the, okay. So the other thing we want to do is to make sure that the episodes meet certain standards. We do have some quality metrics. Some of them are going to be required to pass, some are for tracking, but we want to have at least, if we're going to reward physicians and hospitals for being a commendable or effective provider, we will expect them to reach certain levels on some quality metrics. Now, we do have a pay-for-performance program in Medicaid where we are expecting people to get a B+, A- in order to get the bonus payments. In this case, we're hoping people to get at least a B-, C+. We're not going to be setting really high standards, but we're going to be expecting a certain level of performance in order to qualify for the bonus payment. Some of these quality metrics do require, though we try to use administrative data, we do have a few metrics that require some submission of data on the web. And again, we try to limit that as much as we can. If you don't want to submit those measures, well, fine, but then you wouldn't qualify for gain sharing. So to qualify for gain sharing, you would have to submit those measures. Again, very limited number, but again, something to at least we can track the quality of care being provided. Next slide. These are the current episodes: total hip and knee, perinatal, ambulatory colds, heart failure. This is a hospital-based one, and ADHD. And on the other side of the slide, we'll see who the PAP is, the principal provider, orthopedic surgeon. The first person to see the cold could be an ER doc, could be that'd be a cold in the OBGYN. It's the OBGYN or the family doc, whoever did the delivery and had taken care of the patient for at least 8 weeks. The hospital for CHF, and again, a variety of PAPs for psychiatric or psychological care. Could be the PCP, depending on the level of ADHD being provided. That's a fairly complicated measure, but again, that's not for today's discussion. The new measures being worked on: cholecystectomy, colonoscopy, and tonsillectomy, as well as oppositional defiant disorder. I think do I get a prize for getting them all right? Okay, next slide. We are working on the new measures for cholecystectomy. We're hoping to get the analytic report cards out in April and give you some feedback for the second quarter of 2013. And then, if you will, start the clock or start counting episodes starting in the third quarter, which would be about the summer of 2013. We'll start talking about the cholecystectomy episode. And basically, this is the 30,000-foot map. Patients can present to a outpatient physician, a surgeon, or a primary care doc with chronic symptoms of a gallbladder, get worked up, found they have gallstones, get sent into a referral surgeon, who then makes a decision about whether it's an inpatient procedure or an outpatient procedure, makes decisions whether it's an open or a laparoscopic cholecystectomy. Likewise, patients can present acutely in an ER, may have a acute cholecystitis, be brought in the hospital again, or perhaps sent home and get an urgent procedure, again, inpatient or outpatient, open or or lap. There are a number of patients that may have a primary disease that results in the gallbladder attack, like pancreatitis, and we're probably going to exclude those from this because it's a different episode of care with different sets of costs. But for the most part, there'll be some, I guess about 20% are in acute cholecystitis, about 80% are chronic disease, and then decisions get made as to the location of the procedure and whether there is an open or a closed. And the laparoscopic procedure can go laparoscopic or get converted. Then you have post-op care, number of days, or a number of hours in the outpatient facility or being sent home, and whether or not there are complications. All of that gets thrown into a cost bucket at the end. Next slide. So you have a number of decision points: costs of value, again, appropriate indications, length of stay. For the most part nowadays, this is an outpatient procedure. The choice of care settings, whether you can continue with a lap or whether you've gone straight to an open, and then again, complications and management of those complications.
What we're hoping to do is define an episode that ultimately, where we define kind of the boundaries of the episode, and we define what services are included and excluded, what patients are included or excluded from the performance metrics, with the goal of rewarding providers for things that they can control or that we would hope that providers would seek to influence in the future, and insulating providers to the extent possible from those things that are really not only outside of their control today, but that we don't believe that even in a better operating system in the future that they would be able to influence. So that's the goal. This page is just a summary of some of the data that is to follow. So just as context, we looked at over 3,000 cases performed in Arkansas. About little over 800 that were Medicaid cases in 2010, and then about 2,300 cases that were for which Blue Cross Blue Shield was the primary insurer. And as you can see, and as won't be of surprise to you that are in general surgery practices, the vast majority of these are performed laparoscopically. Only around 5%, less than 5% overall, are performed as open cases, including both those that are scheduled as open cases as well as those that started out as a laparoscopic procedure and then converted to open. We do see a more meaningful percentage of cases that are performed on an inpatient basis. Certainly, almost all of the open cases are done on inpatient, although there are a few exceptions. But we also see a material number of laparoscopic procedures that which are performed on an inpatient basis. And then, sorry, one last thing, Brian, just on the bottom of the page, you just see the number of surgeons that were included in this data. So we saw for this Medicaid population, we saw 122 surgeons performing these procedures, and within the Blue Cross cases, we saw 180 surgeons in Arkansas performing these cases. And it's slightly different time frames, but in each case, those statistics are over a 12-month period. So first, just talking about the episode definition, the scope of services. So we're talking about an episode by any type of cholecystectomy procedure, whether laparoscopic or open. And then it also needs to, so it has to have a CPT code for a cholecystectomy procedure, and the primary or secondary diagnosis has to be for a condition related to cholecystectomy. The time frame that we include is not just that procedure and the inpatient stay, if there is one, but we also look upstream, if you will, to 30 days prior to the procedure, at least for those claims where the diagnosis code indicates that it's related to the cholecystectomy procedure. And then downstream, we look at related services, looking out 90 days. And then for readmissions to the hospital, so this could be for an inpatient case where the patient is readmitted back into the hospital within 30 days, or it could be an outpatient cholecystectomy procedure where, again, within 30 days the patient is admitted into the hospital. We include those, and we're using the new CMS criteria for that, which includes some types of readmissions that are excluded as being unrelated. Then for the exclusion criteria, as Dr. Golden indicated, we want to exclude from the episode those cases that are truly outliers. And we do that in a couple of respects. Here you see a list of examples of the types of cases that are excluded as outliers for clinical reasons primarily, because of significant catastrophic circumstances that are unrelated to the cholecystectomy. We also have the example of patients diagnosed with acute pancreatitis. Those are we would propose should be excluded from the episode. And then others are exclusions just based on what kind of insurance the patient has, as well as age. And then last that bottom dash there, we're also excluding any cases that fall outside of just an outlier cost threshold. And so we're looking at cases that are more than 3 standard deviations above the mean. They're excluded without even looking at, we don't even need to consider the clinical criteria. They're just excluded as being extraordinary.